I'd like to welcome you all. Thank you very much for taking time out of your busy schedules to join us tonight. My name's Marcus Harrigan. I'm the co-president of the Benjamin Rush Institute here at Ohio State. And I have the pleasure this evening of introducing our moderator for the event to you. His name is Dr. Ryan Nash. He's an MD, MA, and is the director of the Ohio State University Center for Bioethics and Medical Humanities. He's an associate professor of medicine and holds the Haga Mädchen MD chair in medical ethics and professionalism at the College of Medicine. Dr. Nash is also a clinical bioethics consultant and healthcare ethics advisor for the OSU Medical Center and is the editor of the Ohio State University Press Book series on bioethics and medical humanities. He has published one book, 3 book chapters, and several essays related to bioethics and has presented numerous scientific papers. Dr. Nash currently serves on the ethics committee for the American Academy of Hospice and Palliative Medicine.
Thank you all for coming, and thank you for the 2 student organizations coming together to foster such a healthy discussion and debate. I'm going to quickly try to catch up in time I'm going to fly through introductions of our panelists, and then they're going to present their main points, and then we're going to have, and these will be very brief main points, and then we'll have more of a moderated debate led by me, and then we want to hear what you have to say. I'll go through the format one more time after the introductions. At the far end of the table, we have, Dr. Donald Mack, who as a family medicine physician, has been a family medicine physician for 30 years. He's done birth to death family medicine in a rural setting and continues to see the full range of ages in his office practice. Additionally, he's focusing his clinical time on geriatric long-term care and end-of-life care. His goal is to increase interest and knowledge in the areas of geriatrics and hospice and palliative medicine, with the ultimate goal of improving the care of vulnerable elderly patients. Dr. Mack is also the advisor for the Students for a National Health Program organization at the Ohio State University College of Medicine. He's currently an officer in the Ohio Academy of Family Physicians and the Ohio Geriatric Society. Immediately to his left is Dr. Brad Cotton, who is a full-time emergency physician in the Columbus metro area. Dr. Cotton began his career in EMS as volunteer EMT firefighter and emergency department tech in 1978. Graduating from Kent State University School of Nursing in 1982, his EMS career included 3 years in the city of Cleveland EMS. Dr. Cotton graduated from The Ohio State University College of Medicine in 1991 and OSU Emergency Medicine Residency in 1994, earning several clinical honors. He has served 39 years now in EMS emergency medicine, including 10 years as EMS medical director for Ross County, Ohio, and on Region 5 EMS Advisory Board. Dr. Cotton has published research on EMS transmission of 12 lead EKGs, leading to updating of Ohio EMS board rules. Dr. Cotton is also clinical adjunct professor of medicine at the Ohio State University College of Medicine. Immediately to his left is Dr. Andrew Thomas, who you heard from before. He's the Chief Medical Officer at the Ohio State University Wexner Medical Center. As in that role, he includes the oversight of inpatient and outpatient care and emergency department services at the OSU Wexner Medical Center, which has 5 hospitals, 5 hospitals, outpatient clinics, specialized care facilities, and some of his key responsibilities include facilitating care between specialties and coordinating collaboration between departments, guiding organizational strategies and representing physicians around the business table, enforcing rules when necessary, and perhaps the favorite part of his job, mentoring students, residents, and younger physicians. In addition, even after moving into an administrative role, he has always maintained a connection to patient care and still sees patients a couple times a week. He also helps fund my program, which means I have a conflict of interest. Moderator questions to him may seem kind of softballish. Immediately to his left is Dr. Harry Jha, who is an assistant professor of radiology at the University of Pennsylvania. He's a radiologist and can be, he has his contact. Immediately to his left is Dr. Beth Haynes, who is the Executive Director of the Benjamin Rush Institute. Dr. Haynes has been working full-time in healthcare policy for the past 7 years. She obtained her MD degree from the University of Cincinnati College of Medicine and completed her residency training at the University of Wisconsin in Madison. She also volunteers as an executive board member of Docs for Patient Care Foundation. United Physicians and Surgeons of America, and the Dr. Joseph Warren Institute. There, good. Now, for the first part of the debate, we're going to hear from the panelists. Each is going to have about 6.5 minutes, six and a half minutes, I think I'm going to stand here as the enforcer. I'm a Texan, so it means I may have violent tendencies, so I'll keep you in line. Otherwise, it is going to, I think, move in the direction that I introduced you in, except that we're going to pass over Dr. Thomas and move to him last. So without further ado, Dr. Mack.
Actually, I'm going to yield to Dr. Cotton.
You can yield however you like.
Well, first of all, I want to thank Dr. Thomas for commenting that the dermatologists were able to get what they were looking for out of the Affordable Care Act. I mean, we all know that if you're blonde and good looking, you always get your way, and I'm sure that's how the dermatologists got that. And again, unfortunately, I bear the scars of almost 40 years in the emergency department working nights, or often working nights, so I'm one of those at-risk geriatric folks.
Yes.
But I'm also hopeful, since I'm raising 3 custodial grandchildren full-time, that my custodial grandchildren can also be carried until age 26 on insurance. Again, thanks again I'm very honored to be here today. Decades ago, I was in this same room, and I was here just to learn a trade, to learn a business, and learn, well, not to learn a business, didn't mean to use that word, but I was there to learn a trade, to learn something I'd already been practicing in EMS and in the emergency department for some time. Many of you, I'm sure, have not been exposed to the truth of the matter yet, that in terms of solo practice, in terms of small group practice, it is largely gone. Most of you are going to end up being employed physicians working for a large, probably hospital chain, and it becomes eminently clear, at times, at least I hope you find it uncomfortably clear, at times that you are then working for a chief executive officer and you are a revenue producer for that hospital chain. Okay? That sometimes is communicated very gently, sometimes communicated very clearly, as unfortunately you will find out, and this is part of what drives the burnout of physicians also, as you become another widget in a profit-making chain. I'm honored to be here today, as I said, with almost 40 years of service in the emergency department. In the emergency department, we are the lifeboat in the Titanic of a sinking healthcare system. We try to, every day there, try to take care of all those cast aside to drown by our profits before care healthcare system. Speaking out today on single-payer improved Medicare for all is the right thing to do. I'm here to protect my patients from harm. I tell them to wear seatbelts. I tell them to not drink so much, to stop using cocaine. And I'm also here to protect them from the very real harms that happen to them from a profit-driven healthcare system, of which the U.S. is unique in the world. I want to thank again for Dr. Thomas pointing out on his initial slides that we already, as the government, spend as much money on government-supported health care as does Canada, as does, I'm talking per capita numbers, as does all the other nations in the world that provide universal health care. Everybody thinks the U.S. healthcare system is all private health insurance driven. It is not. That was what, 45%, less than 50%. So we already spend as much money as nations that cover every single one of their citizens. To me, this is a subject of morality. This is a subject of who we are as a people who we are as a country. Is healthcare a commodity like cell phones, like televisions, like oversized SUVs that run me over on the highway in my Ford Fusion hybrid? Is that a commodity to be sold to the highest bidder on the market, or is that a human right to have humane health care, and is that a guarantee that a civilized society holds out to its citizens? Anthropologist Margaret Mead was once asked what archaeological signs portend that a society has become civilized. Mead answered that finding a healed femur fracture proves both compassion and civilization, as these are, in fact, one and the same. Someone did the hunting and gathering, the feeding, the caring for this injured proto-human. Even under the Affordable Care Act, this femur fractured citizen today had better be armed and prepared to be a player in the market, okay, with insurance, deductibles, copays, and will likely end up bankrupt if he's your average working American on the care he will need for his femur fracture. Which society, I ask you, was more compassionate? Which was more civilized? The tribal community or the avaricious market that determines whether you live or die in the United States today? I'm quite passionate about this subject. I worked yesterday, I will be working again later this week, and I will be looking into the eyes and the heart and the soul of those who are condemned to morbidity and death by our U.S. healthcare system that is more instant profit. And I have running way over my time fast, or very close to it. I was going to very briefly here talk about a patient, I'll make it brief, named Tim that I saw in the emergency department. He arrived aphasic and hemiplegic. The interesting thing is I had seen Tim about a month before when he had AFib with RVR. I had a tough time talking him into getting admitted into the hospital at that time. I was able to do so. Tim basically ended up bankrupted by that hospitalization. He was unable to afford his medications, unable to afford his Rivaroxaban, his Xarelto, was unable to afford the golf cart on those expensive ads selling it too. But he came back with a horrendous stroke, aphasic, paralyzed. His life as a father, his life as a caregiver for his family was ended. And it was ended because he lived in a country that values profit more than it does caring for its citizens. I can't speak about this strongly enough.
Thank you. Dr. Zhao, I think I was wrong in the order that we're going to. Please forgive me. We're going from affirmative to opposition, back to affirmative, back to opposition, and then Dr. Thomas with the status quo side. So Dr. Zhao.
Thank you, and thank you for the invitation. And also, I'd like to commend all of you for actually having the intellectual curiosity to organize this, and to your deans and your selectors for selecting medical students of that disposition. Believe me, this is actually very rare. So I should disclose a couple of things about myself. Firstly, where my perspective comes from. I trained in the National Health System. I went to medical school in the UK. I came to America all glossy-eyed. But you should also know my ideological conflict of interest, which is where I stand ideologically. And this may seem strange, but I'm a tree-hugging Buddhist neocon. And the closest ideology that I find here is libertarianism. And libertarianism is actually quite simple. It means live and let live. But it gets a little bit complex, because what libertarianism means is that you know more about yourself than I know about you. And also, you are smart enough to figure out what you know about yourself much more than I can about you. This is a bit of a difficult thing for me to accept, because, you see, when I learned medicine, I learned that the spleen was on the left side. Why? Who cares? The spleen's on the left side. Just learn it. I learned it rote. I practiced medicine, I still do, laden with assumptions. And here I am confronted with a scenario where when I say, you need mammograms, You need colonoscopy. You need to be on statins. You need to be walking 10,000 feet a day, steps a day. That might not be what you feel. People are individuals, diverse. And when I leave my enclave, my very, pro-Fitbit enclave and speak to real people, I find things that are really surprising. And I'll give you one story. A chap picked me up once to take me from Philadelphia to Newark International Airport. I call him the Afghan cab driver. Clearly, he's not the only Afghan cab driver, but he's one of them. His name is Abdul. His actually real name isn't Abdul, but I can't reveal that. He escaped the Taliban, went to Pakistan, came to America, really, frontier spirit, what you had on the Mayflower here 200 years ago. And he started talking about his life experience. I said, look, I don't want to hear any of that. Tell me, do you have a primary care physician? And he said, inshallah, meaning God willing, I don't need to. And I said, Abdul, are you on a statin? And then he said, you see, I have muscle. I don't know what he thought the statin did. But suffice to say, he didn't think he needed it. And I said, Abdul, is your wife having mammograms? And he said to me, my wife, beautiful lady, makes great goat chops that I have every day. No, she's not having mammograms because, inshallah, she is well. And then I said, lastly, Abdul, do you walk 10,000 steps a day? And he said to me, oh, when I was running from Taliban, I used to walk 50,000 steps a day, but I no longer walk 10,000 steps. And then it struck me that Abdul is different. He is different to me. He's different to the people that I hang out with. His level of risk tolerance is different. He's an individual. And how appalling is it for me to impose my affluence, my risk aversion, my sense of what medicine needs to be upon him? And this is the problem. The problem is that medicine in America has grown. We have become a nation of affluent chicken littles that need to be screened, that worry about antibacterial soap, and we impose that upon people like Abdul. And let's move away from Abdul. I'm going to talk about another set of people. I'm going to give another hypothetical name, Dr. Dogood, professor of humanities in Harvard. He was doing very well until he was told that, by the way, you need to pay 10% of your actuarial cost. Suddenly, Dr. Dogood, along with other people, started rebelling. Oh my God, how is that possible? Why did he do that? That plan that Harvard had was better than the platinum plan that you have on the exchanges. Now, the problem here is Dr. Dogood is used to a certain level of care. Abdul is used to a certain level of care. Abdul says, leave me alone. I don't need to see a doctor. Leave your Upper East Side medicine away from me. You know what the real travesty is? The travesty is not simply making Abdul pay for the level of medical care that people that are affluent should have, but the fact that he will never use it. That is not just travesty, that is criminal. And this is what a singular approach will do in the United States. Look, I come from a national health system which has a singular approach. I come from Europe, where there are many countries, but America is different. I realize that. Sometimes it's frustrating and different. Sometimes it's good and different. But it's different. You cannot apply what happens in Taiwan, what happens in London, what happens in Sweden, what happens in Cyprus, to what happens in America. I realize that as a foreigner. Abdul realizes that. You're a nation of individuals. You realize your individuality, and the biggest mistake that we make as physicians is to take healthcare as a one-size-fits-all. It is not simply unscientific, it is wrong. And it basically stems from that silly, utterly ludicrous definition of healthcare from the WHO, which is that it is not simply an absence of disease, but total state of spiritual well-being, which means that if my wife watches the Keeping Up with the Kardashians, she's robbing me of healthcare. That, I'm sure you will all agree, is total and utter bollocks. And once you agree with that, you cannot disagree that you cannot apply one-size-fits-all healthcare to everybody in this country. Thank you.
Thank you. Dr. Mack.
Thank you. It doesn't seem that long ago to me, but it was 1984 when I graduated from the OSU College of Medicine and moved to Toledo to pursue family medicine residency. I then returned to my rural hometown in West Central Ohio, including hospital care, office visits, surgeries like vasectomies, obstetrics, well-child, and nursing home care. Since then, many things have changed in healthcare. I had to stop obstetrics due to the rising cost of malpractice insurance. Charts have gone from folders of papers to EMRs, and in 2010, I changed from being in my hometown solo two-person entrepreneurial group to being essentially a state-employed physician here at OSU. Because of my subspecialty of geriatrics, I focused my practice on teaching and now on post-acute care, rehab, and nursing home population in addition to office care. I believe that a government-based system can provide more compassionate and efficient health care to all Americans rather than the free market. I've lived through the days when pharmaceutical reps would give some doctors, not me, trips to Hawaii and provide endless studies that proved their medication was the best for my patients. I've lived through the days when milk was on sale at the grocery store as a loss leader to get people to shop there, to now when I have almost memorized the $4 list at Kroger and Walmart, along with the free antibiotic list at Meijer, which are used to attract shoppers into their stores. I've also seen my colleagues in the 90s bemoan the loss of the best days of medicine when they didn't have Medicare and private insurance telling them what to do, to Y2K, or January 1st, 2000, when everyone feared that all of our medical computers would crash, through the implementation of the Affordable Care Act, the repeated challenges to the Affordable Care Act, and the acceptance that it's here to stay. One theme throughout my section of practice history has been the competing patient and physician fears of government involvement and the profit motives of the U.S. healthcare system. In reality, during this time, the market-based healthcare system has continued to shrink, where individuals and employers actually purchase healthcare, as we referred to before. Currently, tax-funded medical care is 64% of the U.S. health system, and it's expected to increase to 67% by 2024 under the provisions of the Affordable Care Act. My practice in long-term care setting is 78% government coverage compared to 22% commercial insurance. This is far from where I was when I first started practice, and the majority of my patients paid cash for their office visits. I know it's somewhat historical now, but I would like to give you the Cliff Notes version of an article from the New England Journal of Medicine by Robert Kuttner on February 2008. Historically, it was very important about that time when this debate was starting. In this article, he gives a succinct rationale for why market-based medicine will not work. He states that the incentive in a market-based system is to increase profit, and a profit motive is not without cost in the medical system. The problem with a for-profit system is it creates overtreatment by increasing those things that build profit, and undertreatment by using risk selection, high copays, and deductibles to discourage medical care based on need. Universal health insurance systems are far better equipped to realize the efficiencies of population-based healthcare because everyone is covered, and there are no incentives to pursue the most profitable treatments rather than those dictated by medical need. In 2008, increasing deductibles and copayments caused more people to not seek care rather than to do adequate preventive and ongoing chronic disease management. Particularly for those without insurance, they just avoided care. Further, he stated that defenders of commercialized healthcare contend that economic incentives work. This has created boutique medicine practices such as the use of specialty outpatient surgery centers, which in theory have more cost-effective and convenient care than the hospital-based system. In a government-based system, the cost savings would be then redirected to other parts of healthcare. But in the U.S. system, the savings were pocketed by the surgeons who owned the surgery centers, and the patients with higher multimorbidity were cared for in the hospital, which further put hospitals in the hole. He cites the U.S. system in 2008 as the closest to a rationing system due to high rates of uninsured, exclusions for pre-existing conditions, excessive deductibles and copayments, and shorter hospital stays and physician visits. A universal system does not waste huge amounts of resources on administration, billing, marketing, profit, executive compensation, and risk selection. For example, when the British National Health Service faced a shortage of primary care doctors, it adjusted pay schedules, added incentives for higher quality care, and the shortage diminished. My opposition colleagues promote competition and free choice is important, and I believe that a government-based system could vary from the United Kingdom, where the government runs the whole healthcare system, to the German or Japanese systems, where the government contracts with providers that compete for best practices. To those in the audience that soon be caring for old men like me, I want to give you some hope. While we all know that there are challenges in the current government-run systems of Medicare and Medicaid, Ohio is one of 9 states which are working with CMS to pool the funds from Medicare and Medicaid on the dually eligible population, such as those in my nursing facilities, to develop person-centered, higher quality care. Also, I've heard the importance of how the free market system encourages innovation. I've had to concede that an excellent example of the U.S. free market system is our development of 3 high-priced erectile dysfunction drugs along with many, many TV ads. I've never seen an ad for metformin, but as a geriatrician, I'm encouraged by the report in the Wall Street Journal last week about a National Institute on Aging-funded study that seeks the answer to whether or not metformin improves longevity. After a study in mice showed that it improved longevity, prevented metabolic syndrome, and increased lean mass. To me, that is innovative, and it is a more important question than treating erectile dysfunction. The difference is this study is funded by our government rather than left to the free market.
Thank you. Dr. Haynes.
Okay. Well, I want to step back from some of this big stuff because I want to talk about what we're discussing compassion and efficiency. Clearly, we need both of those for any kind of healthcare system that we have involved. Without compassion, we have no moral compass. Without efficiency, we have a lot of waste. But more than efficiency, you want is effectiveness. You don't want to be efficient in doing the wrong things. We had almost 20 minutes of the status quo, which actually ends up being a big argument in favor of big government. So it's really hard to have 6.5 minutes here to try and counter. We've got a lot more on the pro-government side of things. But I'll try and do that. And part of that is to really step back and look about what are we trying to accomplish with this efficient compassion and really being effective. Healthcare is only a small part of it. All of medicine, all of political economy should be aimed at the greater creation of human flourishing. We have to look at that big picture, because if what you're doing over in one corner of it, trying to create these very visible short-term positive effects, actually ends up creating much more harm in the long run, it's no good. It's as if you have a magic chemotherapeutic agent that will completely wipe out pancreatic cancer. Gets rid of the cancer, but in the process of it, you totally wipe out the patient's bone marrow. You create so much pain and suffering and risk of death that actually the well-being of the patient is worse off in the long run. It's no good. You have to look at the big picture. You have to look at the effects and the side effects. That's what gives us as physicians and our way of looking at things a better opportunity to really create improved methods of trying to solve this problem about how do we provide health care, how do we improve the health of our fellow citizens. And all of that's what we all want to do, right? We all go into medicine trying to care for patients, to make sure that every single individual human being has the best shot at living the best life possible. So we can't look at health care apart from all of the rest of the things that we're doing when we start intervening into the healthcare system. It's a really important issue, and it's a complex issue. It's a multidisciplinary issue. You can't just look at it from the ER, from the family practice point of view. That's too limited. You can't even look at if we lower the uninsured or if we have more people on Medicaid. That's looking at the scene. That's looking at a target audience. That's looking at that cancer that goes away with the chemotherapeutic agent. But what about the rest of the economy? What about the rest of our values? Health is only one of them. People care about leisure. They care about freedom from fear of physical threat. They care about the education. How are they going to better the lives of their children? How are they going to better their own lives, their own education? So health is one small segment of this, and we focus not just on health. Most of these interventions by the government are focused on health coverage, and I would argue that it's insurance, and I disagree with the way that you define insurance. I think that's part of the reason we have the cost problem that we have. And also absent from the status quo, I would have given a whole explanation about why we even got to the situation where we had to have health care reform. Much of it was well-intended, but government intervention that caused a lot of the side effects that led us to where we have people being priced out of affordable health care at no fault of their own. So let's look at that big picture. Let's keep the standard of whether an intervention is good or bad is how it affects overall human flourishing. So how do we get to this? And how do we get to whether government or whether civil society, with markets being a significant part of civil society, is the better way to attend that? Well, let's look at what we've learned on the global stage. Since 1971, 3.1 billion people have been raised out of absolute poverty. That's trying to exist on $1 or less a day. That was not done by government interventions. That was not done by wealth redistribution, foreign aid, the World Bank, none of that. How we did that was we created more prosperity in those countries. How was that done? Through free enterprise, global trade, rule of law, protection of private property rights, free, entrepreneurship. This is what is raising the world out of poverty. Now, are there still poor people? Yes. We are so much better off than 40 years ago. So much better off because the pie is growing. We have learned what is that engine of prosperity. And if you look, what's this got to do with healthcare in the United States? What it has to do with it is if you're trying to improve the health of the populations, not just even the whole human flourishing, 5%, maybe 20% at the most of people's health is actually determined by the access to health care. Most of it's income, education, and lifestyle choices. Those are poverty issues. We need to know how to deal with poverty issues. And if your cure for a failing healthcare system does not take into consideration how it got to the mess it was in the first place, what those unintended consequences of government, well-intended but unintended consequences of government intervention, you don't have the big picture. You don't have the whole story, and your interventions are going to continue us down that route of causing more harm than good, of injuring our potential for full human flourishing for each individual. To say nothing of how you are disempowering and taking away people's individual rights in the process of doing this.
Thank you. Dr. Thomas.
Thank you, Ryan. I'll just take a couple of minutes because, as was pointed out, I did get 20 minutes to have the floor at the beginning. So I hadn't really thought of it that way. But a couple of things. I guess first, thinking about the resolved behind us on the screen, I think there's probably 4 words that are really important in that. One is government, and one is market. But the other 2 are efficient and compassionate. And I think to the discussions that all 4 of my predecessors have made, I think it gets down to what is your philosophy about, government and market are pretty clear, all things considered. But what is compassionate and what is efficient is a little bit, even though we may think we know what those words mean, if you look at them through different lenses and different value systems, you may come up with very different answers about what compassionate is versus what efficient is, or either or. If you look at the distribution of healthcare costs in the United States, and this actually trails not only across all patients, but if you look within Medicaid or within Medicare, some of the same statistics tend to fall out. The top 1% of spenders annually in healthcare, in terms of from a patient perspective, spend about 20% of our total dollars in healthcare in the U.S. So 1% of the people spending 20% of the dollars for their patient care. 5%, the top 5% spend 50% of the dollars. The bottom 50% spend 3% of the dollars. So to the point of what's the utility of what's best for the most, there's a lot of rational arguments to be made that most people don't need a lot of insurance because most people don't need to spend a lot in any given year for their insurance. But I think, once again, it gets back to that risk versus benefit. Are you willing to take the risk you're not going to have a car accident this year? Are you willing to take the risk your wife isn't going to get breast cancer this year or not? And I think as an individual, it is important to be able to make those value judgments. At the same time, as a society, we've made the decision that anyone who walks into your emergency room, you need to take care of. And that's the law of the land as it is now. And I think when you see somebody who's out riding their motorcycle without a helmet on, who doesn't have insurance, but yet knowing if they get in an accident, the system is going to have to spend hundreds of thousands of dollars to try and help them get better, even though they're never going to have to pay a cent and they didn't pay anything in. It strikes me as a balance between the two, that everybody does have an individual role in making sure that they have some sort of coverage so that they aren't a drain on the system if they're in that small 1 or 5% that spend a lot of dollars. At the same time, I'm not sure that the government is the only way to get that done. That's why I'm sitting in the middle, right, between these folks. I think that the market does have an opportunity to be more efficient than the government. When I look at the issues that are going on in the VA, there are some major problems with the government delivering health care. When I look at what's going on in Medicare or Medicaid versus the private market, there's some benefits of Medicare in terms of overhead costs, in terms of the ability to drive change through the system by having one set of rules instead of having multiple different sets of rules for every insurance company. So once again, I'm kind of sitting in the middle because I feel that it's not a clear-cut answer either way, and I feel like the status quo from our society's perspective solved some problems, much like as for those who've taken my class, any piece of legislation or public policy solves some problems, doesn't solve some problems, and creates some new ones. So we have to deal with the outcome of that. There are going to be new problems created, and it certainly didn't solve all of them, but when you look at the issues of the uninsured and at least cost to the federal government for health care, it seems to be solving some of them moving forward.
Thank you, Dr. Thomas. Now it's the speed round. In round number 2, where each will limit to 3 to 3.5 minutes. We'll go with Dr. Cotton.
Speed round.
I'm sorry. Dr. Jock. I get out of order again. Now it's opposition,
That was a speed
then
round.
affirmative, then opposition, then affirmative. So Dr. Jock, so sorry.
No problem. So it's
you so much.
always very difficult arguing against emergency physicians who really are the backbone of this country because of EMTALA and because of the fact that they've taken on board the risk of society. But let me just go away from that. Has anybody been to Vermont recently? No? It's a great state. Leaves are green, and if you look at the people carefully, you'll see a blue halo emanating from their head. If you look at it very carefully, it's uniformly blue. It's the bluest of blue states. It's noble. It does all the things that progressives want to do. It marks their genetically modified food. The one thing this blue state has been unable to do is pass single payer. And it's really ironic. It's actually hilarious how this happened. The governor that wanted to pass a single payer got onto the platform, i.e. got elected because he wanted to pass single payer. Then he got elected again because he didn't want to pass single payer. Why? Where's this paradox? Why? Because it costs. Because everyone said single payer, great idea. It's like what I say when I say, do you want a Ferrari? Of course. Do you want to pay for it? No, not really. So single payer, great idea. Then he looked at the bill, 2.5 billion and rising. Why was it 2.5 billion? Why wasn't it 1.7 billion or 1.2 billion or 1 billion? Because people wanted to have 94% actuarial level, like platinum plan, right? They wanted to have their cake and eat it, like Marie Antoinette said, let them have cake. But let them have cake costs, ladies and gentlemen. It costs. And if you really have humanity, I want to see you put your money where your mouth is, because otherwise it's all rubbish to me, right? It's all utter rubbish. So I love my brothers. Well, let me see how much you want to sacrifice for your brothers. Not much. This is the bluest of blue states. This is a state that believes in, what's that term called again? Economic patriotism. It's another name for taxation, by the way. But you've got to laugh at these Orwellian terms. You know where people stand with single payer. They don't want it. They don't want it. Let's stop harping on about it. It's like Britain. They don't really want to leave the European Union, but every 4 years there's going to be some Brexit plan. Let's leave the European Union. Shut up. Stay there. We know you don't want to leave it. Stop wasting our time. This is the reality of single payer. Now, let's see what the government's done. This government, this jiu-jitsu fighter, remember those old, kung fu movies where you got this guy going in front of Bruce Lee saying, hoo, 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 and Bruce Lee just slaps him on the face. This is what regulations are like. They're like the guy that goes, hoo, 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 hoo. EHRs, 30 billion, can't even achieve interoperability. Let me hear what the government can do. Nothing. Nothing. 30 billion, you had your chance, sir. You did nothing. Control prices of drugs, Nothing. Martin Shkreli is laughing at big government. The only argument for single payer that it will control drug prices, devices, no. You know what the single payer will do? They will bully doctors. They will say, you're responsible for fraud, you have conflict of interest, but with the rest, with pharma, with devices, they will be in the laps of them. Deny it, because that's where they deserve, denial.
Thank you, Dr. Chow. Dr. Cotton.
Thanks. Briefly, I guess I often like to take kind of a historical perspective on how this argument has gone throughout U.S. history or world history, for that matter, between the private and between government. I just recently made a trip to Pittsburgh. I was hoping to visit the site of the Homestead steel strike there, where Andrew Carnegie, where we think of as some tremendous benefactor that gave us libraries, through his intermediary, had his steelworkers shot down with rifle fire in cold blood when they tried to support the idea that they shouldn't be working 60-hour weeks for cut pay and have very little benefits. If you look at, this is a period of history is not often covered well in the United States of what the status was of the common laboring working person before we had unions, before we had some sort of protection for them. I cite a personal example. My own grandfather in 1912 was a child laborer shoving coal into the boilers of Great Lakes Freighter. This was an idea that was just fine with free market theory. This is an idea that was just fine with libertarian small government people, is that we don't need any rules, we don't need any regulation, the market takes care of itself. I suggest reading a novel of Charles Dickens if you really want to see how the market works when left to its own. The Christmas Carol, for example, is not some sweet story about Christmas. It's a story about the poorer classes in London and what happens when there's no rules and no intermediary, no referee. The only protection for us from corporations, from health insurers, from pharmaceutical companies, is for somebody to set the rules. I'm frankly kind of surprised that we make references to international learning in a derogatory way, and that we make references to efficiency. It's in fact, if you look at multiple international comparisons, and I say we can, or actually maybe part of the trouble with America is that we can't learn from anybody else. We have this idea of American exceptionalism, that we know everything. If you look throughout the world, healthcare systems that function well, that take care of everybody, that don't leave anybody to starve and freeze to death outside of the city gate, work very well around the world, whether they're single payer. I frankly am not in favor of what they do in Britain. I more like the idea of Canada or some other countries where it's basically like Medicare for everybody. Doctors and hospitals are still independent. Your doctor still makes the decisions, and there is no interference, or very little. In terms of efficiency, this has been found to be efficient. It works well. Single-payer systems spend about half what we do in the United States. And a lot of that goes to waste. Dr. Thomas talked about the medical loss ratio and how the health insurers were not happy that they were going to have to spend 80% of what they perceive as their money. They perceive of your premiums as their cash, and they hate to spend it on you. But the Affordable Care Act says they have to spend 80% of it. Medicare, government is supposed to be huge, waste, and ineffective, runs on 3% overhead.
Thank you. Dr. Haynes.
Okay, so let's talk about the fact that markets have nothing to do with lying, cheating, or stealing. Markets rely on rules, but they rely on proper rules that respect individual rights, that you have a right to your life, to your labor, to your property, and not to other people's. It relies on the fact, the moral stance, that no one can be made the unwilling means of another's ends. Everybody has a right to live their life. Nobody owns anybody else. That's what the United States is based on. That's the morality behind the United States, behind good civil society, and behind markets. It's got nothing to do with lying, cheating, and stealing. The other error I want to correct is that profits mean greed. If you properly understand economics, profits are nothing more than a math calculation. That's all they are. How much did it cost for you to produce a good, and how much, or a service, and how much was somebody voluntarily willing to pay for that good, and what's the difference? That's a profit. And if you think there's no greed in capitalism or in markets, you're wrong. There's greed, but it's not the profits. It's individuals. Profits are showing added value. This is the extra wealth. This is what we've created above and beyond the resources we started with. This is new wealth. This is value added. And if you also think that there's no greed in politics, you haven't been paying attention to the presidential election. So profits is not the same as greed. And greed exists in the market. It also exists in politics. The difference in a market system is that you're dealing with people who interact with each other on a voluntary basis. You don't like one business, you get to go to another. But as soon as you put something into the realm of politics, now you're dealing with the properly delegated institution of coercion, which should be protecting people from the lying, cheating, and stealing of anyone, whether that's a business individual, whether that's somebody without any kind of resources of their own and they decide to rob you on the street, or whether it's another politician. Cronyism is not an aspect of markets. Who empowers the cronies? It's the government that allows cronies to exist. So profits are not greed. And very quickly, you have to think, if you want to understand about whether healthcare is a right, you need to understand when you say healthcare is a right, what does that mean? It means you have a right to somebody else's labor and property. And there is no right to healthcare, not even in the countries that claim there's a right. All you have is a right to the healthcare that the government is willing and able to pay for, nothing else.
Thank you. Dr. Mack.
Yes, thanks. I guess I agree that profit is not equivalent for greed, but profit routinely has had misdirected motives in the U.S. and puts the onus in the wrong areas so that people aren't taken care of. I also agree with Dr. Haynes that a picture of well-being is probably more than just healthcare provision, and I get that. But I guess I would also say that part of well-being is that we provide for everyone at least some level of a safety net or care rather than seeing great segments of the population go without care. And when we say big changes on that, I guess the thing that my experience has been is I've had patients choose to go to another physician just because they had a $3 copay versus a $5 copay. I mean, their decisions are made on very small amounts, which, doesn't seem to make sense maybe to, economics and the market system. Also, I've had patients that won't get any of their prescriptions and come back and see me because the prescription, even though they were on Medicaid, they had to pay a $2 copay. I mean, these are real day-to-day experiences that I have as a provider. I don't have that luxury always of having something that's covered by everything or patients that have access to those kind of financial resources. When she talks about the boon and the getting people out of poverty, I still see poverty. I guess the other thing that the other point I would like to make as rebuttal is that, we've talked about the differences to a certain extent between the U.S. health system and many other countries. And it's still, like always, is a source of dismay, just frustration to me that we have the richest country and yet, and we have the most expensive healthcare system. And yet we consistently have the worst health outcomes according to the report of the Commonwealth Fund, which is independent. Like I said, the market forces I see every day are very small dollars, but very real dollars.
Thank you. Dr. Thomas.
Just a couple of comments, kind of a half agreeing and half disagreeing with both sides. I agree completely about the concept of if the government were to be more involved, as the resolution says, that it should be only on the insurance side and not own all hospitals and employ all physicians. I think, once again, with the way the VA looks to me, that doesn't seem like a system that would work very well. I still, though, feel like that the mix we have of private insurance and individuals being able to get private insurance through a marketplace, with some governmental insurance for some populations which are more at risk, so the elderly or low-income individuals, is a nice mix. I think your comment about markets have rules, I think is very important. Once again, thinking about how the marketplaces are designed, there are rules and levels that create transparency so that the average consumer that maybe knows how to buy a TV or knows how to pick between two different restaurants, but you start shopping for health insurance without transparency, it gets very difficult. So I think the current system, once again arguing for the status quo, has rules and transparency that allow individuals going out to the market to choose between different private insurance plans, not requiring them to have a governmental plan, allowing flexibility in what they choose between the bronze, silver, gold, and platinum levels. We didn't even talk about catastrophic healthcare or health savings accounts, which are another option which provides a very low premium cost, allowing you to put more at risk by having a very high deductible. And if you choose not to be insured, you don't go to jail. You just pay a bit of a penalty that helps fund the care for everybody else. And although I agree with you, that is taking someone's earned goods and using it for potentially some other purpose or someone else's benefit, at the same time, if that person who's uninsured shows up in his emergency department, they're going to get care, no questions asked. So I think where we're at as a status quo is not perfect by any means, but compared to having the pendulum swing too far one way or too far the other, I think it's kind of a Goldilocks option. It's not too hot, not too cold.
Thank you, Dr. Thomas. Now for final closing comments, not final, but closing comments for this round of this side of the debate. First, we'll hear from the affirmative side.
Go ahead, just go ahead.
Y'all can arm wrestle which one.
We were just deciding.
Go ahead.
Again, we've heard a lot of talk about misappropriating in terms of taking other people's property. I guess I look at taxes as part of what I pay for the privilege of living in a civilized society. I'm glad that we have police. I'm glad that we have fire services. My background is, in fact, working in EMS and fire services prior to going to the emergency department. These are publicly funded, publicly paid for services that protect us, but they are not taken, you do not voluntarily give them up. The no government libertarian dream would say that if you don't pay taxes, your house burns down when it catches fire. We don't let that happen. We live in a civilized society. The argument both for compassion and I argue passionately on the compassionate side of things. We can't leave people to die. And I see these people who have nowhere else to go in the emergency department. And I think the emergency department is an excellent way to view the healthcare system because that is where we see the failures, the people that have nowhere else to go. I forgot, frankly, where I was going with that, but you know, we do, the market system does fail. The market leaves. Prior to the Affordable Care Act, we had 50,000 deaths as estimated by a study from the American Journal of Public Health in September 2009. It's 50,000 people a year that died because they had no health insurance. With the Affordable Care Act, we may cut that in about a half if we had complete compliance with Medicaid expansion. I give John Kasich credit in Ohio, and I hate giving John Kasich credit for anything, but he ran an end run around his own party and got us Medicaid expansion in Ohio. I couldn't quite read your sign there.
2 minutes.
2 minutes,
Happily.
okay. We look at profit also. Again, I work because I get paid for it. I work what I think is on international comparison, emergency physicians tend to do pretty much the same in various healthcare systems. But there is some, we need regulation, we need rules. I'm glad that Dr. Haynes agreed that we do need some regulation and rules, and the source of regulation and rules comes from you and me, comes from government. Otherwise, we have a whole lot of Al Capones running around setting their own rules. And by Al Capones, I don't draw that much of a distinction, frankly, with some of the behavior of pharmaceutical companies and health insurers. Prior to the Affordable Care Act, if your wife developed breast cancer, the health insurers would go back and look through her application and find out that she didn't comment that she had hay fever or something as a child. That was called rescission of benefits, would then go back and take away her policy, leaving her with absolutely nowhere to go. The Affordable Care Act put an end to this kind of stuff. That was legalized murder in protection of profits, the rescission of benefits. We look at talk to some of the oncologists about the pricing of oncology drugs. Many of the oncologists have been very upset about the extremely high prices set for some of these, and many CEOs occasionally, when they've spoken truthfully, have said that these prices were set because the market will bear. A cancer patient will pay about anything. Hepatitis C drugs are $1,000 a pill, $84,000 or $96,000. In India, it's about $900 for a whole course of it. The price of albuterol, which a lot of people with COPD need, before it had to be reformulated, was basically on the $4 list. They had to reformulate it, and now the price is like $50, $60 for an inhaler. People can't afford it.
Thank you. Now for the opposition side.
So really what we are arguing about over here isn't zero government or zero regulations, it's what do we need more of. And what we need more of, it's best to look at it from the pre and post ACA. Pre-ACA, people were rendered bankrupt because of these horrendous charge master rates that had no bearings whatsoever on prices. Post-ACA, they're still bankrupt to some extent by these horrible, horrendous charge master rates. So where is that big government? Where is that daddy that I was looking for? Nowhere. Pre-ACA, pharma had unlimited mandates to charge whatever they wanted, including $1,000 a pill for Sovaldi. Post-ACA, they have the same mandate. So tell me again, where is that big government? Where are you when I need you? Nowhere, in pharma's hands. So I'm afraid to say that big government has disappointed marvelously. And really, the question now is, what is the role of private enterprise? Now, of course, one can't replace the entire system of private enterprise. That would be ludicrous. But as Abdul told me that he doesn't have a primary care physician, I do know that in West Philadelphia, where Abdul lives, there is one chap who provides primary care services to Bangladeshi, Pakistani, Afghani communities that are not rich enough to actually have employer-sponsored insurance. How does he do it? He takes money. Oh, God, shock. Oh my God, he takes money. Well, of course, he needs to educate his kids as well. He takes money, $50 a pot for a visit every now and then. He manages their diabetes. He phones up labs and says, look, you can't charge them $200 for a silly FBC, CBC. Get it down to $10, because otherwise they're not going to get the lab test that he needs. He looks after them. This is called private market. This is called free market. This arises in a system that is heavily regulated. And it is unbelievable to me, the moral ambivalence of paying $1,200 to $1,500 a month on insurance, and that's okay, but the moment you have to fork out money for direct pay, that's immoral. Where did we become such woolly thinkers? How did we arise to this level? And when you look at the role of the government, not only is it incompetent when you most need its help, it actually is responsible for a lot of the over-medicalization that we have. You know, this overdiagnosis, giving people disease when they don't have it, that came from public health because of screening, Because somebody said, oh, it's not enough that we pick up the disease when you actually have it. We need to find it beforehand. And guess what happens? You rip people's prostates, make them impotent and incontinent when they don't have disease, overdiagnosis. You rip people's breasts, bilateral mastectomies, overdiagnosis. You give them pre-diabetes, giving them lifelong anxiety. That's all a result of government, not private enterprise. Because you know what private enterprise would do? Private enterprise would go to Abdul and say, hey, listen, you want to pay $200 for to have your prostate checked out? He say, go, piss off. I'm feeling quite well. But with government, it's all in that little pool of insurance. So before you go around pointing fingers, realize who you're pointing fingers to. We don't need more government. We need smarter government and more private enterprise. And this idea that healthcare is a right is meaningless. Go to Northeast India, healthcare is a right. You have nothing. You have a right to this boondog hospital provided by government that provides absolutely nothing. People gag to have private enterprise there. Healthcare as a right means absolutely rubbish.
Dr. Thomas.
I think I'm going to pass on my 2 minutes and move on.
Okay.
To Q&A.
We'll go on to the moderator Q&A. I'm going to have just a few comments, and then I'm going to ask for your response in basically the same kind of order that we just went in. I have so much I could say, but I'll restrain myself. So I think one of the problems, and just a couple things, in reading Dickens, I would read Dickens as calling for charity, not for government intervention. Just as the Christmas Carol, I read it every year to my family, and it's calling for charity, which can be done. I see all sides. I see no one saying stick it to the poor. It's just how that charity would be given. You're arguing for government. Others are arguing for other ways. So I think one of the large things that what's missing in debates often is that we have this huge cost problem. I don't see the ACA doing anything to fix cost. It may bend the curve a little bit, but it's going to pop right back up. Universal health coverage, even if it's other countries are spending a lot of money, we may be really expert at spending more than anyone else. So no one can make an assertion that if we move to a universal health care system that it would save money, that we would, I think that's a non-starter. And we spend much in kind of the system we have, which brings up one point. We don't have a free market system. We didn't before the ACA, and we haven't since Medicare was passed. We have a hyper-regulated system that takes away market incentives. The things that help contain cost in a market, like having to pay for something, having transparency in billing, don't exist in our system. We have nothing that approximates a free market system. Our system currently takes away the advantages and the positive aspects of a market. So those are just a couple of glancing thoughts. Another is that the biggest challenge I think we have is societally and individually, we have unrealistic expectations on what medicine and healthcare can deliver. As societally, we look to medicine and healthcare as a source of eternal life. That has to be fixed. Societally, we need to be more embraced with our own finitude. And I think hospice and palliative and other groups, at least the early movements, I don't know so much about the modern movement, but the early hospice movement was trying to bring death back away from the institution and back into our community so we could realize, wow, we all have this terminal condition called life. And medicine and healthcare is not going to solve it. So I think that's the overarching view. But to get to a question for you to respond to, I think the resolution has a couple of quandaries. One, can government do it? We could debate on whether, well, it could theoretically, but should it and will it? I would think should. That's, well, probably not. And will it? Oh, I surely don't think. Could it? Possibly, maybe it could. But more, I want to focus on what I think is a false dichotomy. We talk about government and market. I really think it's a false dichotomy in that market is a reality, not an ideology. And what I hear is more about market ideology. Market is that there's going to be intended and unintended consequences that affect the realities of an economy. Okay? So a free market system doesn't exist. I don't know of a free market system in the developed world. So we have a hyper-regulated market in medicine, but it's not free. So what I want to bring up is a puzzle of what I think is a government system that uses market pressures to provide excellent care, and that's the puzzle of Singapore. So brief overview, Singapore in all ratings of healthcare is in the top 5. Bloomberg ranks at #1 in efficiency. World Health Organization ranks at #6 in compassionate care for the poor. It's #2 in the world for infant mortality. By all measures, it's a successful system. It spends, talk about economic efficiency, 1.6%. So government spending in Singapore is 1.6% of its GDP. 1.6. Our government spending is somewhere more like 10% of our GDP. Its overall spending on it may be more like 8%, probably 8%. But our overall spending on healthcare in Singapore GDP is 4.6 to 7% of the GDP, where ours is 17%. Okay, 17%. Now, what Singapore does is it has a multi-tier system. It has a universal health care plan that with a single-party government service for any citizen of Singapore. Okay? But nothing's free. You always have that market pressure that you have to pay something out. So if Abdul says, no, go piss off, I don't want your finger in my rectum, then fine. He doesn't have to pay his $3 copay. He can walk away. So there's this, and the poor are provided for. If you are above a certain income, you have a compulsory, again, around the ACA, we talked about compulsory, but in Singapore, compulsory, you have to save into a program called MediSave. And when you come to the hospital, you have to meet with a business officer. You decide which tier what kind of care you're going to get, whether you're going to get really comfortable care or whether you're going to get Taj Mahal with gourmet chef care. And you can, the difference between MediSave and Medicare is that MediSave is a defined contribution. So you build capital. They have lots of money sitting there that can be spent. Unlike Medicare, which is a defined benefit, basically, where we have no money in the Medicare system. It's based on this year's budget, and, well, last I said, that budget deficit keeps going up. So now, above MediSave and above the universal payer, you can buy insurance. And there's a whole private sector of medicine that you can consume from. And then you can buy concierge service. You can have basic service, which is good, world leading. You can have better basic. You can have concierge. It's your choice. But all levels use the market to incentivize social capital. They encourage families to stay together because you can exchange MediSave money from family member to family member. If grandma gets sick, you can say, well, do we pull our resources and put her in an institution, or would you care for her at home? It has many aspects like that. Now, Singapore is about 6 to 7 million people, the size of many states in the United States. And I wonder, why haven't we had a national debate over whether Ohio could be a Singapore? Why can't we have that experiment? I turn it to the affirmative.
I would say that one of the challenges, of course, that we have in the Singapore system to the U.S. is, again, that free will. It's required that everyone contributes, everyone saves, but also the other big thing about the Singapore system is it's a fairly more uniform, I think, system in that everyone gets health care versus, ours where you may or may not get health care depending. So, I mean, there's a lot of good things about Singapore. I also like that they require everyone to save for home ownership. So the other thing they've said is that may help on some of the social determinants too, because everybody has stable living and stuff. And so it makes them more efficient. I think it also improves their health outcomes. But I think we would have, just as we tried to form the Affordable Care Act and get everybody on board that we should have a basic set of insurance, I think it would be very difficult in the U.S. just because everybody wants to protect their own choice and freedom. And so I think it's going to be tough, but I'd love to have the Singapore system.
It would be difficult in Texas, I can guarantee you. So it's difficult in the U.S., but would it be difficult in Ohio?
I think it would be very difficult
Or
still in
Michigan,
Ohio.
or in Michigan, or in a place
Yeah,
like that?
Ohio is very much wanting independent access and independent things.
For the opposition, any responses?
Well, I think it's really important to realize that we still haven't had a chance to delve into how did we get to the place where so many people have been priced out of affordable health care. And so what you're talking about is a system where there is a greater and greater number of people who are in that category. Why do we have that? And yet, why is it that the shoeshine guy at the airport can afford a smartphone? So the other thing that you didn't mention about your description in Singapore is how wealthy it is per capita. It's a very wealthy, it's a very market-oriented system to begin with. So I have to study a lot more about Singapore and understand it. Certainly, we are not going to move, and I would not recommend us moving to a fully market-based system from where we are, because the most vulnerable people in our country, the sick and the poor, are the biggest victims of the system as it is. It was not a free market before. It was a heavily, heavily regulated healthcare industry, and the ACA took all those regulations and doubled down on them. It's making it worse, and the costs are continuing to go up. So without understanding the history of why the United States is so much more expensive, what is the cost, and why do we have so many people who can't afford it, much of which is due to not just since Medicare and Medicaid, that accelerated it, but certainly started with the Flexner Report and a lot of other interventions that occurred prior to Medicare and Medicaid. You have to understand that history, and you have to understand how prices come about in a market. Really important to understand that discipline of economics before you make any kind of judgment about healthcare policy.
Any brief comments, Dr. Thomas?
No, I don't know that much about Singapore, except I think caning was just considered
Yeah,
unconstitutional
don't
there
chew gum.
like a few months ago for males aged 16 to 50. But I do think the idea of looking at the political lens, that knowing each country is different. I think this was one of your points earlier in terms of understanding where this country's come from, whether you're looking at the Teddy Roosevelt version of healthcare, the FDR version of healthcare, the Truman version of healthcare, all of which actually got smaller in some ways as it became the Medicare, Medicaid, Lyndon Johnson version of healthcare. It was only for the elderly and only for the low income compared to where it was back, 50 years before that. I think that you do have to know where you came from to know where you need to go in the future. And I think your point that if we were to go to a more free market based, we still need to provide protections for those vulnerable folks in the population.
Absolutely.
So that's why I think to some degree it's a bit of a false question to say it's all one way or all the other. And that's why I'm sitting in the middle.
Right. Thank you. Now it's time for audience questions. I'll have the two student leaders field these. Go ahead. Energetic. Stand. I'm behind you. Right there. In the glasses. You. Pointing to yourself. Wait, they're going to run like Oprah or Donahue or whoever you watch.
They don't know who Phil Donahue is. They weren't even born then.
They don't know what a Chevette is either.
Does it work?
I could have said Pinto.
Sears catalog.
Yeah.
Does it work? Okay.
Yes.
So one comment and one question. So one of the comments I had, just really briefly, the argument of the smartphone, 70 to 75% of the whole world has access to cell phone technology, and I think the Cochrane Council recently said that level of communication is a basic necessity in order to be a functional part of society. So the idea of people being able to afford smartphones and cell phones and not being able to afford healthcare, I think, is somewhat of a fallacy. But that's aside, that was just my comment. My question is, we've heard a lot of the more philosophical debates about free market versus single payer. For me, I'm really interested in how that affects healthcare outcomes, right? So I think for a long period, there was this real motivation to improve quality of healthcare. Recently, that has shifted to cost. And with the ACA, one of the
the basic value proposition is to increase value rather than just increase quality and reduce cost. You want to do both. So my question is, in the ACA, it's more of a population-based system where individual hospitals are responsible for the population around them. So reducing readmissions, increasing or decreasing social cost, increasing return to work time. And so the fee schedule kind of reflects that. How would a free market system be able to care for that, care for a population where you guys have mentioned individuals? How do you measure that population effect? How do you incentivize caring for populations and reducing readmissions and increasing value rather than just reducing cost? Does that make sense?
You know, part of it is who gets to decide what is value, and how does that even come about? How do you know what is valuable? Who gets to decide that? And are we going to delegate that to a small group of experts who gets to decide for everybody, or do we crowdsource it? Markets are crowdsourcing. Markets are trying to allow individuals to decide what is important for them. Now, as a physician who knows more about healthcare, we can advise them, but they get to choose. Rather than putting some of these crazy, so you talk about this incentive with the no readmissions. You know who doesn't get readmitted? It's the patients who die in the hospital. Right? There's some crazy ways that if you just quit taking all the really sick people, you won't have people that get readmitted. So there's a lot of problems with the way these quality measures have been set up, have decided, as opposed to the way that you improve quality in a market. It's Olive Garden has to compete against the Cheesecake Factory, right? And it's those guys that are deciding, we're going to start offering value. What is that value? And then the customers get to choose. Now, in a more complicated thing like healthcare, it becomes more incumbent upon us as physicians and advisors to be able to offer that advice. So it's trying to understand how you actually discover. Value is not something that a bunch of people sit around in a room and come up with and try and impose on everybody. It's a discovery, and it's an individual discovery. It's something that you crowdsource. And the systems within the ACA are trying to use that small group of experts deciding for everybody else, and then we're going to set the prices, and we're going to say what's value, rather than allowing that to occur much more organically. It's not real value.
So the only reason we're here is because we're spending too much money on healthcare. I think we can all agree on that premise. And I'm going to make an assertion that I'd like to have all of you that care to respond to. And the assertion is as follows. We have not got a problem with the cost of healthcare in America. We have got a huge problem with the price of healthcare in America. Martin Shkreli, the most hated man in America, is an invention of the United States government because you can buy Daraprim in India for 10 cents a dose. But we have a government that says that he's the only guy who can sell it in the US for, what was it, $1,700 a dose or something? We haven't got a problem with the cost. We have a huge problem with the price. Where does that breakdown occur, and how do we fix it?
To respond to that very briefly, I would just say look again at the international data. There's excellent information available from a group called Commonwealth. In fact, there's multiple sources of international comparison of healthcare systems and how they function. The U.S. is about twice as expensive or more than any other system, and it's because of administrative waste, inefficiency, profit, CEO bonuses, big buildings, the cost of buying congressmen to support, your system. Every other, if you haven't believed a word I said today, look at the raw data from world comparison. They do a better job. I'm not sure what my time allotment is here if everybody else needs to speak, but 31% of all U.S. healthcare dollar gets wasted on too much administration. If you go see your doc, he's got 4 or 5 people in his office who are working just to argue with all the insurance companies. The insurance companies have 4 or 5 people. You want them to argue back with those 4 or 5 in your doc's office. And finally, after about 6 months, whatever you want might be approved, but meanwhile, all these people have gotten paid and there's a huge amount of administrative waste. Medicare runs on 3% overhead, okay? There's just a huge amount of waste in the U.S. system, and we just need to look at international comparison and realize we can learn something from other countries. I hope that answers the question as you posed it, but.
When I look at the international cost comparisons, I think it's important to remember that whatever number you quote, 15, 16, 17% of GDP in the United States that goes towards healthcare, depending on what year you look at. The question isn't, is that too much? The question is, are we getting what we pay for? And I think part of the issue in terms of the cost of healthcare is, are we spending that healthcare on the right things? I firmly believe it is a balance between access and personal responsibility. I always tell my patients, you know, my sickest patients, diabetic, hypertensive, coronary disease, I might see in the office 5 times a year. Sickest patient I have is a primary care doc. The other 360 days of the year, they got to be their own doctor, right? I need to figure out what are the cost-effective medications for them to use, what are the lifestyle habits that they need to have to be healthier, and to some degree, maybe it's secondary prevention. I can't make them ultimately healthy, but I can make them less sick than they would have been had they not done those things, right? They already have heart disease and other things. But it's empowering them to do that. Without access, they may not get some of those things, but it's a necessary but not sufficient criteria for success for a patient's health. I think access is necessary, but it's not sufficient. They still need to do other things. To your question, I think if we were getting the outcomes that 17% of GDP bought, that we think that we should be getting, then maybe it would be worth the price of what we're paying. But I'm not sure that we're doing that, because we're spending a lot of money on end-of-life care that's really expensive. We're spending a lot of money on inefficient parts of the system. People that get CAT scans in 3 different hospitals in a 6-week period of time because they just go to whatever hospital they want, right? I mean, there's a lot of ways we could make it more efficient. I'm not sure, though, that the argument that healthcare, it's kind of like saying the federal deficit's too big because of waste, fraud, and abuse. I think the federal government deficit's too big because of entitlement programs. It's not too, if you let go of every government employee, it's like $500 billion. It's not that much money. It's a lot of money that we're getting, whether you're a defense contractor, Medicare, Medicaid provider, a researcher, whatever it is. It's money that's going out into the economy. So it's not as simple as saying it's just overhead, I think. But there's a lot of waste in the system that's just because patients don't know how to use the system well as well.
One clarity. I think we spend a lot on care at the end of life, where end-of-life care usually is.
Yeah, we've had that discussion how many times?
If I could comment, I'm the guy that initiates that most expensive care in the emergency department when no one is ready to let somebody go. We spend a huge amount of money there and a huge amount of incredible torture that we do to patients, which I'm the guy that starts that, unfortunately, because no one will allow me not to.
Yeah, I just want to make a quick comment about this, the Medicare and its overhead being 3%. So part of that is a numerator-denominator phenomenon. It's a math. If you look at what Medicare spends per capita, the cost is the same as in the private system. But the fact that Medicare patients spend a lot more, it's a smaller percentage of the healthcare dollars. So I think it's misleading to say that Medicare has lower overhead.
So I've got to answer your question very specific to Daraprim. So why can't you get Daraprim from India? You can. If you ask me, I'll just bring it in my check-in luggage. It's because of safety concerns. It's because you're a very risk-averse nation. All the regulations that have arisen has come because of the risk aversion. And risk aversion costs a lot. So the reason why you don't have any drugs from India is because there is suspicion that the drugs from India are not going to be pure. And there is some basis to that suspicion. Like with anything else, there's not complete untruth and there's not complete truth. And that is the reason why the FDA forbids hospitals from doing that. Now, One other point I want to make over here is your question with regards to what can what can we do to break that cycle. I think what you'd have to do is you'd have to accept some trade-off, some harm for some good, and it's always going to be that case. If you have an over-regulated system like you have over here, which is really very over-regulated, you have JCO, you have HIPAA, you have privacy concerns that are not known to anyone else in the world. It's bizarre. It really is bizarre. I mean, I've seen people from parts of India, and I've said, well, how does your CAT scan get transmitted? Don't you have privacy concerns? And they say, well, people from here are more concerned about their lives than privacy. This is an affluent indulgence, and you pay for it. You pay lots for it. That's why your health care is expensive.
All right, so I think we're going to have one or two more questions.
First of all, I'd just like to thank everybody for coming out. I thought this was a really great event, and I appreciate it. So I heard the affirmative say something to the effect of the government won't let people freeze and die. My question is, do you believe the contrapositive is true, that people would freeze and die in the absence of government? Would our U.S. society fail to care for indigents?
That's directed at the affirmative. I guess I would answer some of that. We've had some discussion about other countries, and I have certainly many physician friends who are from India, which was one of the countries mentioned. And in that, it's very much a market system. And if you go to the door of the hospital and you don't have money, they just say, there's the door, So I think if it truly was just market-based, I think that there would be some people that would be just not cared for, because if you can't pay for it, what's the alternative? You just stay outdoors. I don't know if anybody else wants to.
I'd answer definitely to the affirmative, and it happens every single day that people are dying from lack of health care. In my opening statement, I told about a stroke patient named Tim, who I actually saw twice. First time he came in with AFib with RVR, and he could not afford his medications because that hospitalization bankrupted him. He came back a second time, basically aphasic, paralyzed. His life as a father, as a caregiver, was essentially over. There's a study in the American Journal of Public Health I referenced, September of 2009, estimates 50,000 people a year in the U.S. died from lack of health insurance. People are dying, and I see it every day. I can't take care of everything in the ER. George Bush, in one of his most callous statements, said, we have universal health care in this country, you just go to the ER. Well, I take care of people when they're crashing and burning. If they're crashing and burning bad enough, I put them in the hospital. If they're not crashing and burning bad enough, they go back home. Either way, they go back home to a system where no one else will follow up. They need specialist care, they need medication, they need more testing. They can't get it. They come back to the ER when they're crashing and burning again. I will see this later this week. I guarantee it was someone who couldn't follow up with their gallbladder ultrasound and has now developed cholecystitis, and it becomes a surgical emergency that was preventable if they could have got follow-up care. I hope that addresses your question.
I just want to follow up with that, because I think it's really false to say, here's this horrible situation that somebody who can't afford their medical care, and that's because we don't have enough government involved. And I think it's exactly the opposite. We have been pricing people out of affordable care because of all the various risk-averse regulations that we have. Even the subsidies end up being an engine for creating higher and higher costs. So these are tragedies, but you can't equate a tragic picture with a cause. You have to understand more to really understand why healthcare costs what it does. And it's not simple to just say it costs a lot, therefore that's the market, because market's what has something to do with prices.
Thank you. So this question is more for the free market people. So, you talk a lot of negatively about the regulation and stuff, but how far do you ultimately think that it should go? For example, with all the educational requirements to become a doctor, to become a surgeon. Clearly that's very expensive on our part in terms of like reimbursements as well. So what should be what's your ideal scenario? Should people see nurse practitioners? Like there's like the Minute Clinic today. I mean, should that even have any regulation at all with medical school? Because if you really want all people to be able to get providers, I don't think everyone can get physicians in that kind of system. So what do you kind of propose ultimately?
That's a very, very good question. I was afraid somebody would ask that. I think it's a balance, and I think at any point in time that balance depends on the needs. You can't have a one-size-fits-all that applies to every generation. At the moment, given the rise in technology and the assistance from lots of algorithms, it's not wrong to have greater involvement of nurse practitioners. That wasn't the case 20, 30 years ago, when the asymmetry of knowledge was a lot more stark, but it is certainly the case right now. So I think it depends. In my profession, radiology, I no longer have to fear people that are not medical doctors. I now have to fear computers. Somebody called Watson might take over my job. And pigeons apparently can read as well as us as well. So, we're in threat from people from ground and also in the sky. So I think to be fair, you should have various people that provide healthcare services. I think if you have a diabetic nurse that knows their patient very well, they would be better than physicians in some ways. I know that there are care coordinators in oncology that have complete knowledge, because what's important there is the transition of care as much as the drugs as well. And so I would completely endorse that system, but retain physicians and retain their barrier to entry for them to provide the extra value that that particular training has. And I believe that that training does have extra value. It's just not in every scenario, in every situation.
I would mostly just say we have to start with where we are. We're in a risk-intolerant society. We've gotten used to not having to think about things through licensing and other mechanisms. So there's not going to be any instant movement in any direction. The question becomes, in what direction is a better movement to head? Is it to increase the ability of PAs and nurse practitioners to practice at the top of their license in a way that makes more care at an affordable cost available to more people? So what's the direction of that we want to move? And if we move in the direction of more and more government being in charge of either paying for or mandating the quality of medical care, what are the side effects? What are the problems? If we try to open that to more and more empowering people to make better choices individually, more of that crowdsourcing, which direction is a better direction to aim at? Not that we're going to hit either extreme, ever.
Great. Thank you. This has been a great debate. Thank you to the panelists. I think I'll hand it over to student leadership for the vote.
Yeah, that about wraps it up for us. Thanks again, everybody, for coming. If you are interested in these topics, please feel free to reach out to Dan or I. We would appreciate if you took the time to go to this link before you leave and complete the post-debate vote. And thank you once again for joining us.